Sorry. Sometimes just not knowing the X-ray is enough. Sometimes you need to know what you are looking in the X-ray. Okay. And sometimes in some of the X-rays, only the visuality, or if you are able to make the diagnosis, that's more than enough. Okay. Then coming the PPH of the newborn, it's not that crazy, but the thing is, what could be the related things with PPH, and usually present within 12 hours. So we're talking about PPH, persistent pulmonary hypertension of the newborn. So it's usually present within 12 hours. And in this one, the most important is checking pre and post ductal oxygen levels. Okay. Just because of this line, this whole topic is important. Okay. Yeah. So then secondary PPHN more common in the term and post-term baby. So usually what you check is pre and post-ductal oxygen level, then hyperoxia test checking for if this sinus is coming from cardiovascular or wherever it is coming from, ECG, echo, and all that. Usually giving the only oxygen. Then comes the respiratory distress in the newborn. So all you need to do is this table: RDS, TT, and MAS. It's like something, mainly the chest X-ray, as I keep on telling you. How does the RDS look like? It has homogeneous infiltrates, air bronchogram, decreased lung volume, may resembles pneumonia if swear white out with no differentiation of the cardiac border. So that's why the RDS is important. How does the picture look like? Okay. Then TTN is basically perihilar infiltrates, well sealed fluid in the fissure. So there is fluid. So you can think of pleural effusion could be there. Then meconium aspiration, it's mainly in the post-term baby. So think of the babies who are big, who are diabetic mother. These are the very catchy words that can help you to figure out what's going on. So in this one is hyperinflation, patchy atelectasis, patchy and coarse infiltrates 10 to 20% of pneumothorax. But I'm just telling you, like they can ask you label something, and like this MEC is important, where they can ask you the air in the diaphragm or intramural, but they won't give you something like ask you to label if this is an atelectasis or whatever it is. Okay. So like they will tell you those questions which actually make sense to you. Okay. So they will not give you something complicated. So that's why don't think of yourself like going for very stupid things. I hope that makes sense. Like if you are going for, let's go diaphragmatic hernia, now you can tell the bowel loops are in chest. So if they ask you in the scenario, labeling that, bowel loops are in the chest, and put the arrow mark and ask you, write down one and ask you what is there, what did you see there? So you can tell this is bowel loops, right? But they will not ask you like this here, this is a patchy infiltrate, by putting a label on something and be like, what is this? It's a patchy infiltrate or not. So things that will make sense to you, things where you are able to make the diagnosis, only at that place where you will make the labeling in the x-rays. That's what I'm trying to say. So don't like complicate yourself. I'm not trying to scare you, but I'm trying to prepare yourself. So if any weird scenario is there, so you are mentally prepared for that. RDS is basically the pre-term, TTN is basically term and late term, and then MAS is basically term and then post-term. So usually like a bigger babies. Then what else is there? RDS and TTN is mainly in the male sex male sex, like the male boys. In RDS, there is hypothermia as well, and mainly like you can think of RDS with some sort of infection. So acidosis, sepsis, hypothermia, these are the things. In TTN is basically C-section and short labor. So these are the words. Okay. In meconium, there is basically post-term delivery. Okay. Prevention, what are the prevention for RDS is basically the steroid. What are the prevention for the TTN is basically where possible avoidance of elective C-section and only particular before 38 week. Then meconium, if infant is depressed, then go for C-section right away, or either intubate and suction the vocal cords, avoidance of the factors associated with the uteropassage of the meconium. How do you treat resuscitation, oxygen, ventilation? All of these for like even for like all of these three diseases, we go for resuscitation, oxygen, and ventilation. Then in RDS, we go for surfactant. In TTN, we go for IV fluids and NG tube. And in the last one, the meconium one, we go for surfactant, nitric oxide, and intracorporeal membrane oxygenation for PPHN. This is something they can ask you, like what you're trying to prevent, and what is the treatment to prevent. Extracorporeal membrane oxygenation, and what to prevent PPHN. Okay. Then the complication, we already are aware of that TTN can cause hypercapnia, acidosis, PPH, and hypoxemia. And ADS is basically RDS is bronchopulmonary dysplasia. And this one, it causes everything: pneumothorax, pneumomediastinum, chemical pneumonitis, all this. Okay. So if you figure out, the mainly thing that you need to know here is risk factors. How does it look like the clinical features? So you are able to make the diagnosis, then chest X-ray, then the treatment, and then prevention, and then complication. Okay, so you don't need to worry about the prognosis, and you don't need to worry about etiology. Then coming to the sepsis is one of the important thing. Like many of the answers are sepsis in neonatology. Like I feel like if wherever I am stuck, I just choose sepsis. Like if there is fever and things are making sense to me, then I just go for sepsis, and it do save me a lot of the time. But yeah, that's something that you are doing in practical life. But yeah. Early onset and then late onset. Early onset is less than 72 hours. Late onset is 72 to 28 hours. So in early onset, they mainly like to ask like the torch infection, vertical transmission, UTI, GBS, previous child with the GBS. So this is it something here. Uh, in which cases you are thinking that this child might have a GBS. If a child is born like a same from same mother, a previous child was born with GBS, in the next child who is born and he has fever, you can think of GBS. Okay, so this is something that can be asked in the question. Then prolonged rupture of membrane, fever, leukocytosis, chorioamnitis, and preterm labor. Then what are the clinical features? So you know how does it work, vomiting, and then you know the hypotonia is one of the most important thing and can be given, and petechiae and purpura. So it can give you fever, hypotonia, petechiae and purpura, and ask you to make the diagnosis. So think of sepsis. CBC, then we are doing the full septic workup, and then for the other septic workup. Then the sportive care, IV antibiotics, and then all of this one. Addition of IV acyclovir if it's HSV infection. So I think it's in the obstetrics where we will do a little bit more about GBS. I'm just giving you an idea about the GBS point of view. What is important? This one, maternal infection, like in which causes there is GBS in the children. So a mother who has UTI, a mother who has GBS positive, or the mother who has previous child with GBS, or like sepsis and meningitis. So in those cases, we think of GBS and we do check for GBS testing. Okay. Like it's a MCQs that's like that was like circulating and one of my friends shared with me. So we have a very big discussion where we have to do the GBS one. So that's why it's stuck in my mind. And I'm letting you know that this one they were looking for and we could not find in the whole Toronto notes. And it's just written here. Common neonatal skin diseases, what are those ones? Vasomotor, vernix, then congenital dermal melanocytosis. Like usually the pictures, how does they look like? Capillary hemangioma, erythema, then milia. Milia is something they can ask you, like, what is the treatment? So basically reassurance. Transient pustular melanosis, nevus simplex, and the neonatal acne. In this one, what you need to do is just figure out where you have to do the reassurance and which one is dangerous. Okay. So in HUS, we do avoid like antibiotics, this one here. Avoid antibiotics, NSAIDs, antidiarrheal drugs, no treatment associated with the improved outcome. So that's why only sportive treatment, that's it. So don't go for anything. Just because of, sometimes some topics are only important because of their prevention. So if you figure out or see some words where they says do not, avoid, prevention, like give it a quick read. There is no harm in going through that words, because in the exam mainly they are looking for if you are a safe doctor or not a safe doctor. And who is safe doctor? Who knows what you don't have to do. You can do anything. I'm not sure, like you can do CBC, whatever. But in some cases, there's a clinical diagnosis. So in those cases, are you aware where you don't have to do CBC? Then you are being called a safe doctor. Like if I am working in an emergency department, any patient can come with a fever. I can do CBC, and I have no problem with that. No one will say anything to me. But at the same time, am I aware of what I'm doing? If let's suppose a senior came to me like, why did you do CBC? Now I'm not able to justify. Now I'm not a safe doctor. And they might put me in my bad record, be like, oh, this is not a safe doctor. Okay. So it can affect a lot of things. So in that case, it's just wherever you find something, avoid, prevent, do not, like these things, or this is a clinical diagnosis. So in those cases, you and then exam, they do like to ask these questions. Then the nephrotic syndrome, proteinuria, hematuria, azotemia, RBCs, cast, oliguria, and hypertension. Usually we go for dipstick. Then the nephrotic, what is nephrotic? Hypoalbuminemia, edema, lipids, and proteinuria. In the nephrotic, the main important is I don't know what's the name of that one. Yeah, minimal change disease. That's very common. In those cases, we start the oral prednisolone for 12 weeks. Varicella status should be known before starting it because chickenpox can be triggered or shingles can be triggered. And then the child will present with edema of the eyes and then leg. Like he has more edema in the morning time, in the night time, and we notice that this is going on for too long and whatever it is. So in that cases, you can think of MCD, minimal change disease. Then what is the symptomatic treatment? Edema, we go for salt and fluid restriction. Hyperlipidemia, go for limit dietary. Hypoalbuminemia, IV albumin, and then BP, control the BP. What is the diet intake? Okay. Supplement with calcium and vitamin D if on steroids. Like anyone who is on steroid, always think of calcium and vitamin D to give along with them. Is a vaccination, no? So antibiotic prophylaxis is not recommended. Pneumococcal vaccines at diagnosis and varicella vaccines after remission, it should be given. Okay, this is the line. Then in hypertension, mainly we think of endocrinopathies, Wilms tumor, congenital adrenal hyperplasia, just for your idea. And then obese children always think of some sort of depression, and obese children think of steroid, like high blood pressure too. And usually when a child presents with hypertension, we always check their kidneys. So bijou and creatinine. So, try to think of logical ways where you have to encounter some sort of these questions. Treat underlying cause, non-pharmacological treatment, weight reduction, exercise, salt intake, smoking, and drug cessation. Some of the child we do have to counsel about junk food as well. CP child is one of the most common presentation. Okay. So it can present with spastic athetosis, ataxia, and mixed. So it can present in any forms. Mainly the child is the one that is exposed with the torch infection. Now I got the thing. This is what they were asking. With the torch infection, what is the most common complication? This is the CP child. And in the CP child, what is the most important thing that you would like to rule out? Torch infection. Okay. So that's what I was thinking about. Torch infection is one of the most common in the prenatal causes, maternal disease, congenital, and then prematurity, low birth weight, infection, and all that. But most important is torch infection. Then how do you figure out this is a CP child? We already discussed about, some of the reflexes, they usually finished by 6 weeks, 6 months, sorry. And if they are not going away after 6 months, then in those cases, we think of CP child. So you cannot make the diagnosis before turning off or finishing off those ones. So CP child diagnosis is being made after the 8 months, 6 to 8 months. Febrile seizure is one of the most common seizure. Wherever you have any child who has fever and is presenting with a seizure, or if they present with a seizure for the first time history, always think of febrile seizure before labeling that they have epilepsy. Okay, causes of hypotonia that responds to the rapid treatment, hypokalemia, hypermagnesemia, hypo. So everything is going low except for magnesium. Hypoglycemia, hydrocephalus, infection, ICH, seizures, acidemia, drug and toxin. That's why I said hypoglycemia everywhere is fixed anyway. Comparison of typical and atypical ones. So simple is basically less than 15 minutes, generalized, no recurrence, and there is no developmental delays. There is a very small risk of having epilepsy. But complex more than 15 minutes, there is an incontinence of urine or pass of the stool, focal onset, recurrent seizures, neurological impairment, and then increased risk of redeveloping epilepsy. So wherever this is a first time seizure and it gives you an idea of simple typical, think of febrile seizure. That should be your first diagnosis. Then we're talking about history, physical examination, lumbar puncture, ruling out everything. Febrile seizures do not cause any brain damage, very small risk, and then it usually resolves within 1 year. So this can be asked in the question where the mother is very worried about the child having febrile seizure again. So in that case, you have to reassure that it can resolve within 1 year. Hypotonia, floppy baby. In the floppy baby is also the torch infection, but then don't forget about the other electrolytes. What are the electrolytes? Hypocalcemia, hyponatremia, hypothyroidism. In those cases, it's very common. Neurofibromatosis type 1 and type 2, it's more common in the older people as compared to the young people. And just knowing what are the linked diseases with it and how does they look like. Like what I'm talking about here is neurofibromatosis type 2 is the most common is schwannoma, neurofibroma, lenticular opacities, meningioma, glioma. So they can be asked like it causes hearing loss because of schwannoma and all that. So one of the problem is like, as you can see here, bilateral vestibular schwannoma. So thinking about the hearing loss is something that's very concerning and you have to think of it. Then headache red flags. Do read the headache red flags. What are those ones from? If there's a worse headache, focal neurological, constitutional, worse in morning, worse with bending over, change in the level of consciousness, sudden mood change, pain that wakes patient, fatigue, and then school attendance. Very, very complicated lines or words of this epilepsy, that epilepsy. So you can read. One of the thing is here for the childhood absence epilepsy. I mean, in that case, is the child is only staring, okay? And then you can say the mother presented to you, the child is only staring at one place for like, certain time, and he's not responding even when you are talking to them. What could be the diagnosis? So in that case, is think of childhood absence epilepsy and how do you treat it? Valproic acid or ethosuximide. Then here is one of the thing, the approach. How do you approach or what are you going to counsel the mother when you are going to discharge for the seizures? It's one of the most important topic of NACOSCI, but since again, you never know, you can be getting the question from here. Education for the patients and parent education. So medication, you can give the medication and telling them compliance. So how, like today we actually checked a patient where we're checking her phenobarbital level and valproic acid, and the levels were low. So in that cases, what are we going to do is call the patient, checking for compliance of the medication and letting them know maybe we need to increase the dose. Okay. Continue anti-epileptic drug therapy, ketogenic diet, like high-fat diet, are used in the patients who do not respond to polytherapy. And then Ministry of Transport. So we always forget about this high-fiber diet. Sorry, high-fat diet. Then talking about asthma, one of the most important thing from asthma is when are you going to label that child with asthma? So before 5 years, it's very less likely we do label it as an asthma. We do consider it as an respiratory distress syndrome, and we just like acute respiratory distress syndrome, and then we treat it like that, but we don't write it down as an asthma before 5 years because we have to do spirometry, and spirometry cannot be done before 5 years. Okay. So oxygen salbutamol can be given, then it impratromium, prednisolone, no response, then observe and then discharge. In chronic cases, education, Ministry of monitor respiratory relief therapy like salbutamol, and then controller therapy is also salbutamol along with uh, corticosteroids. Then second line is also corticosteroids. What is the indication where they're not able to breathe, choking, and where the salbutamol is not helping? Main important in the steroid is when, sorry, child, when are you going to label them that they are asthmatic? Then bronchiolitis, lower respiratory tract infection is the only lower respiratory tract infection very common in the children's with less than 2 years. So what is the most common causing virus is RSV. In this one, routine investigations are not required, so we don't do anything. It's just a viral thing. We don't do anything. It's a self-limiting, all of that. If child do present with a lot of oxygen or respiratory distress, in that cases, you do refer them to emergency and then they get high flow oxygen. Otherwise, it's a simple, straightforward thing. So self-limiting disease, mild to moderate oxygen, per oral IV hydration, then severe cases go for oxygen. Bronchodilators, corticosteroids, and antibiotics have no therapeutic value. So don't think this is asthma. Then cystic fibrosis, you can see, read the sidelines. I don't usually go into very detail of this one. It's mainly what is linked with which thing. Like it can, like the main thing that can be asked is hyponatremia. So they can give you a hypotonic baby where he's having a insufficiency and he's having chronic failure to thrive symptoms, and everything is, and then there is rectal prolapse. That's very common. So in that cases, you can think of cystic fibrosis, simple, the diagnosis. And in the older people, they do like to ask, it can cause the decreased fertility. Usually because many of these diseases already been screened in the neonatal, like screening. So in that cases, that's why we are not going for that one. Sweat chloride test, CFTR gene, then mainly the nutrition counseling where you give the high caloric diet and pancreatic enzyme. Respiratory failure, pneumothorax could be there. Then comes the pneumonia. In pneumonia, what is obviously the X-ray. There is one thing here. No? Yeah, the treatment. For neonates, what is the treatment? Ampicillin and gentamicin. For 1 to 3 months, it's ampicillin or ceftriaxone or azithromycin. It's 3 to 5 is amoxicillin. So mainly it's amoxicillin. Then more than 5 is amoxicillin. Okay. But they can ask you a question where the penicillin sensitivity or penicillin allergy. In those cases, you need to know what is the next one. And mainly where there is penicillin allergy, we don't give ceftriaxone as well. So always think of a third option. Because when they mention about penicillin allergy, if you write on ceftriaxone, this is wrong. Then this table, croup, bacterial tracheitis, epiglottitis, and choanal atresia. In this one, the main three is epiglottitis, bacterial tracheitis, and croup. In these three, the most common is epiglottitis and croup. In those two, the most common is croup. Okay. So just to letting you know. Then this is basically croup is subglottis, tracheal bronchitis is basically trachea, epiglottitis is supraglottis, and choanal is basically nasal. This presents common in children. This one is decreased with the vaccine. So this one is linked with vaccine. Always think of the vaccination point of view. Parainfluenza, influenza, RSV. So this is basically bacterial. This one is with the Haemophilus influenza. This one is oronasal membrane. What are the clinical features in this one is barking cough. This one has the cough along with biphasic stridor. No response to steroid. Then epiglottitis. This is basically for 4Ds. Drooling, dysphagia, dysphonia, distress. And then choanal atresia is basically for the noisy breathing. Investigation going for chest X-ray. This is basically if you see, although we go for chest X-rays, steeple sign, whatever, you can see this is a clinical diagnosis, and this is also inability to pass the NG tube. So if you choose chest X-ray, it's wrong. Although I'm not saying that doing chest X-ray is wrong, But if you choose in your exam that for crew, what is the investigation of the choice or what will you do next? If you choose chest X-ray, it's wrong. It's a clinical diagnosis. So you have to be very confident. They say no investigation, none. Chest X-ray, culture and sensitivity, or whatever it is, A, B, C, whatever it is. So in that cases, the none is the option. Okay. Then in this one, it's a clinical diagnosis. Clinical diagnosis, this one is also physical examination, avoid excreting expected. So in this one, going for steroids, this one intubation and IV antibiotics, intubation, IV antibiotics, and then acute, where you put the oral airway initiative gavage feeding. Growing pains is one of the most common. Which age? And sometimes they can present with the pains in the leg, and then all you have to do is reassurance. Simple. Here is the something table you can see for the differential diagnosis, okay? Like in this one, the most important is leg calf prosthesis, slip capital femoral epiphysis, and Osgood-Schindler disease. So leg calf prosthesis is basically 3 to 10, more than 10 can present, but slip capital femoral epiphysis is more than 10, and Osgood-Schindler is also more than 10. Just to let you know, the slip capital femoral epiphysis child will be mainly obese. The word obese you will be able to find, and that is basically with the slipped capital femoral epiphysis. I mean, I see a lot of MCQs from slipped capital, and the word I find in that MCQs common is obese or overweight or a chubby child or someone, something like that. Okay. Then the red flags of the limb pain is fever, pinpoint pain, pain out of proportion, night pain, weight loss, erythema, and then unexplained features. Then comes the septic arthritis. In that case, is the treatment. Neonate is different. What is that one? Fluoxetine plus gentamicin. Infant is cefazolin, then cephalexin. Then child is basically cefazolin, then cephalexin. Adolescent is basically ceftriaxone. Transient. Transient sinusitis of the hip can lead towards the leg calf prosthesis disease. Kawasaki disease is very, very common. What is the presentation? Warm more than 5 days, conjunctival injection, then rash, edema of the hand and feet, adenopathy, and mucosal changes. Polymorphic rash, cervical adenopathy could be there. In those cases, go for IVIG. But main important is what are the disease that can be linked with this one. So it's basically fissure lip, strawberry tongue, and injected pharynx. So it's more common in the Asian people. So it can cause the heart disease, mainly aneurysm formation. The one they are looking for is aneurysm because 50% of the child usually has aneurysm, large coronary aneurysm. Okay. So I think that's about it from the pediatrics. Tomorrow we will try to finish the pediatrics from my notes first. Then we will do if there is any medicines of pediatrics that I have written somewhere, like any notes from there. First, we will finish that one and then we will move on. And the next topic we'll start is obstetrics. Okay, just to let you know. So do finish it from here. The topics I have read is very, very important. And the other topics, if you have time, you can go through them anyway. Okay, so the words I have told you, mainly the treatment you have to do, which antibiotics you have to give for neonates, for older, for age, whatever the factor is. Okay, then mainly sometimes which complications, like which disease can cause which complication. And in some, you need to see the picture like x-rays or whatever the baby look like. And in x-rays, sometimes you need to localize what is the thing that you are looking for in the x-rays. And age factor is very, very important. If this child is male, what could be there? Oh, sorry. Before starting obstetrics, there is another chapter of this speeds. We'll finish that one. I think it will take only tomorrow. So we'll finish that one. And then from day after tomorrow, we'll go to the obstetrics. Okay. So any question from today's class?